Well, good morning. Oh, you okay? Good morning, everyone. Can you hear me? Good morning, and welcome to Grand Rounds. My name is Mark Olfson, and I want to start with an announcement. Next week, at the same time, our very own Lisa Dixon will be presenting, and she'll be talking about early treatment of psychosis. How did we get here, and where are we going? She's an expert and an articulate speaker, so I hope you'll mark your calendars and join us for what promises to be a very interesting talk. Today is the Mumford Award, and each year our department honors the legacy of Emily Mumford by recognizing an individual for his or her outstanding contributions in social science to our understanding of mental health. And before introducing this year's Emily Mumford awardee, I thought I'd take a moment to tell you about Dr. Mumford, and she's the attractive woman you see here on the screen, who passed away in 1987. She was a professor of socio-medical sciences at the Mailman School, and she ran the Division of Healthcare Utilization Policy here at PI, very much the forerunner of what is now Lisa Dixon's division of behavioral health and healthcare policy. Anyway, Dr. Mumford's best known for her discovery that people who receive psychotherapy tend to adopt healthier lifestyles and therefore decrease their use of unnecessary medical care. And she was careful in her writing, though, to point out that this isn't the reason for providing mental health care, but rather an incidental and welcomed consequence. And this so-called cost offset has been observed in various other settings, and 30 years on, it continues to be of interest, particularly to healthcare policy makers and health economists, when during periods of healthcare reform, such as where we've been in now for a number of years. So her legacy lives on there. She also did important work, early work, on using videotaping as a tool to teach residents basic interviewing. She developed rating scales and so forth, and described all of this. And today, 30 years later, there are many departments, including our department, that uses videotaping as a tool for psychiatric interviewing training. It's a great pleasure to introduce this year's Emily Mumford Awardee, James Jackson, and he is the Daniel Katz Distinguished University Professor of Psychology, also a Professor of Afro-American and American Studies, and a research professor, all at the University of Michigan, where he's been at the Institute for Social Research for a number of years. Professor Jackson has made a number of important contributions to understanding of social determinants of health. He's focused on Afro-American individuals in the Caribbean and further south in Guyana, as well as here in the United States. He studied immigration. He's looked at the relationship and the influence of race and ethnicity on life course, on stress, on reciprocity, and social support. A lot of this work came out of an important epidemiologic study that he ran, the National Survey of American Life, in the early 2000s, and it continues to be a rich trove of information and generating a steady stream of important publications on these topics. Some of the work that I know has sort of made the largest impact on me is the attention that he's drawn to the adverse effects of perceptions of racial discrimination, and how they have strong adverse effects on health, and particularly mental health, in a variety of settings, and really sounds, to my reading, the call to efforts to combat discrimination in all of its forms. It will not come as a surprise to you that we're not the first people to recognize Professor Jackson's accomplishments. He is a member of the National Academy of Medicine. He's a fellow of the American Academy of Arts and Sciences. He's a fellow of the American Association for the Advancement of Science. In fact, he has so many accomplishments that if I were to read them all, I wouldn't leave him much time to talk, and I promised him last night at dinner that I'd give him a full hour. I know you'd rather hear from him than hear from me, so I hope you'll please join me in welcoming this year's Emily Mumford Awardee, Professor James Jackson. And as a token of our appreciation. I have an award I just want to show the audience here that we'll be giving Dr. Jackson. I'm going to do this in a way that it doesn't fall out, which is always a risk. So you see the, I don't know if people can see it there, the award.
I can see it, though. It's gorgeous.
Okay. All right. Very good.
Thank you very much. I appreciate that. Well, nobody could be happier to be here than me. Mark, I really appreciate that generous introduction and kind. The last time I was here, I think, was 30 years ago or something like that, although time, for some of those who are a little older in the audience, you know, time gets a little funny, and the older that you get. But literally, for a whole bunch of different reasons, I'm the happiest person in the room that I'm here now giving this talk today. I'm going to talk about some of our newer work, but I do want to run through fairly quickly some of the older work, which kind of sets up the kind of work that we're doing right now at this particular point. The culprit in this story, in my estimation, is chronic stress, not acute stress, but chronic stress, and it plays a prominent role, I believe, in a lot of the things that we observe. I also want to talk about a model which looks at the interrelationship between physical and mental health. It's an interrelationship which we oftentimes pay a lot of lip service to. Everybody knows there's a relationship. We just don't study it. We either study one or the other, but we don't study what the interrelationship might be between that and what indeed may be the causal mechanisms that operate to give us a relationship between individual physical health as well as their own mental health. I want to acknowledge this is a cast of thousands that have worked. Our Social Neuroscience of Health Disparities Work Group, SNOD, so you know that some graduate student named this. It's true. And this just lists a lot of the people that work with us, both at the University of Michigan as well as other places as well. And it really doesn't get all of those. At the second part, I have no conflicts to report. I didn't make a slide for that. I know sometimes we do that in medical school settings. I don't have that. But I'm thankful to lots and lots of generous support from the NIH and foundations and other kinds of stuff. And I list all of that there, as well as from the University of Michigan. It's a real pleasure to give this talk. Emily Mumford's work, a lot of people didn't know. I did not know her. She played a very prominent role, though, in a area of research that we did work, which had to do with regard to health seeking. How do we understand it? We took her work to begin to look at what the interrelationship was between informal and formal health seeking and how they operated together. Buying into her notions about the importance of psychotherapy and other things, and having a role in mitigating the use of physical health services. I am an illustrious company. There are a lot of people who've given this talk. I won't list all the names. I did look them all up, and it gives me great pleasure then to talk to you today. This may be the high point. I'm going to say a lot of outrageous things today, so hopefully you won't walk out, but this is the start of it. The broad dimensions of this talk, and I don't want to think about this as an outline, but I'm going to talk about the issues of chronic stressors and stress. We'll talk about disparate differences in material well-being. We'll talk about some of the racial group disparities that exist in physical and mental health. And we'll talk about motivation and self-regulation and other psychological processes that operate in health. Finally, at the end, I'm going to talk about what I call the masquerade of racial group differences, and I'll draw some summaries and conclusions at the end of my talk. Rice is something that drives us and has for a very long time, and RICE actually is an acronym for race, immigration, culture, and ethnicity and gender, including issues of age and SES. And we've always been interested in the intersection of these particular factors and how they play out over the individual and group life course. So we are in a demographic transition. I don't think the kind of national policies that have been promulgated right now is going to slow this down in any particular sort of way. We have a growing diversity of the population. We have a need to understand something about intra-group studies. We do a lot of research on the Black population in the United States or the Latino population in the United States, which are very heterogeneous populations with lots of differences within them, and we need to understand what those differences are. We also need to do work on intergroup studies, and we do a lot of that. There's a lack of knowledge in this particular area. And finally, we've been concerned about what some people have called a paradox. A paradox is something where you think you don't know the answer to. We don't call it a paradox because we think we know the answer to this. So that's what I'm going to talk about today. At the end of the talk, you might say, well, I still think it's a paradox. We'll see. We'll see where that goes. You know, however you construe race or ethnicity, there are two processes which are operative, and I think it's very important to note those. There are biological processes, whether in skin tone or other kinds of things that are there, and there are lots of issues that relate to social. It's far-fetched to think that somehow biological processes alone could account for what we observe in terms of group differences in physical and mental health. Social processes must play a major role, and it's what we're interested in. So we think the major culprits for producing stressful effects and risk for poor physical health and psychopathology among ethnic and racial groups may be chronic environmental stressors and discrimination. So we study discrimination and perceive racism as a class of stressors. Discrimination operates in the context of social, political, economic, and cultural influences over the individual and group life course. And discrimination and perceived racism, as well as other non-race related stressors, are tied to poor structural life conditions. So we don't argue that it's all about discrimination and racism, but we do argue that it's a class of stressors that, along with other stressors that people have to face in life, create the kinds of difficulties and problems that we see. The law of small effects is a very important idea. I want to make sure that you understand that. There's no one single factor that produces observed physical and mental health disparities in processes and outcomes among race ethnic groups in the United States. It's a group of small differences that accumulate over the life course that produce the kinds of differences that we see among those particular groups. And this is a very important point. If you're searching for the factor that produces disparities in either physical or mental health, then I think you're going to be sorely disappointed. There are lots of factors that are involved in very different kinds of complicated ways. The fundamental assumptions that we make is that focusing on a population group like ethnicity, race, gender, so on, in contrast to focusing on a categorical disorder, requires attending to a broader array of interrelated and multidisciplinary research perspectives. I can't say that in important. People sometimes look at my vita and they say, my God, what do you study? Well, I study economics, I study political science, I study issues having to do with psychiatry, I study all kinds of different issues. Because if you're concerned with regard to the health of a population group that is under the kinds of pressures that African Americans are in this particular society, then you have to attend to a broader array of factors that indeed affect that particular population. It's particularly true when that group has been the object of poor treatment and discrimination. Disentangling the meaning of good psychological health and individual psychopathology is confounded by the existence of this real group mobility barriers and related biological, social, economic, and psychological factors. That's an important point to make. Sometimes I get very angry that African Americans are discriminated against in this particular society because as a scientist, it would actually be easier to study this particular group if indeed they were not the objects of this discrimination. Discrimination confuses a lot of things that we try to understand as health scientists about what the relationships are. One of my favorite, I call this the bicycle presentation. And it just makes the point that psychopathology is actually unobserved. We observe psychopathology through the reports of others and self in terms of observed symptoms. It's affected by the environment that people are in, and all these particular issues interact with each other. And this is not to get into discussion about DSM and RDoC and all that kind of stuff. I'm not trying to talk about that. They both suffer from this kind of notion that psychopathology is kind of an unobserved phenomenon. So give you some examples about race and how we understand it. Ancestry, timing, and age of immigration matter for Black Caribbean mental health. So if we look at this, and this data is from the National Survey of American Life, these are the totals. This is non-Hispanic whites, this is African American, and this is Caribbean Blacks in the United States. And we find the characteristic finding, which I'm going to make before, that as far as mood disorders are concerned, the prevalence rates are higher among non-Hispanic whites. In fact, as I'll show you in a slide later on, there's been no study that I know of that's ever been done that has ever not found this particular finding. This is a consistent, constant finding. And in fact, there's a reason for that. Caribbeans, we hadn't studied too much before. They kind of come in second and close. But the point is that when people come to the United States, really make a big difference. The three blue bars are first generation, and you get the kind of first generation protection that we see with lots of other kinds of groups with Caribbeans, so that those who are indeed second generation and subsequent generations have much higher rates of mood disorders than those who are indeed the first generation. And you find some jumping around on this, but for the most part, you get this particular effect. So the question is, could the lifetime disorders be a function of time in home country? And so we looked at 12-month, and you get exactly the same effect. So it's not that it's something about the time in country. There is something about this first-generation protection. Another question that we like to ask is, what does it mean as we look at different kinds of age groups? So you see the same kinds of effects for those people who are 18 to 34 that we showed before. We see the same kinds of effects for those who are 35 to 54. But what's interesting about this is that for those people who are indeed 55 years of age and older, that effect disappears. So that those people who came the most recent here actually suffer the greater prevalence of any disorder if they came when they were 45 years of age or older. So gender, ethnicity, and immigration status matter. Now we're looking at, again, complicating the story about how we understand racial differences, which I'm trying to show you here. And this is 12-month prevalence of any mood disorder by ethnicity, gender, and immigration. What's interesting about this is that Blacks show the characteristic effect, females having higher prevalence rates than males. But notice that Caribbean Blacks, US born, show just the opposite effect, that Caribbean Black males actually have higher prevalence rates than females. And that indeed, this tends to reverse, though, for those Caribbean Blacks who migrate to the United States of America. If we look at major depressive disorders by ethnicity, gender, and immigration status, again, we find the same effect that we showed before with regard to lifetime disorder. Persistence of disorder, and this is a very important point to make. So even though the prevalence rates for mood disorders and particularly for major depression are higher for non-Hispanic whites than African Americans, when African Americans are diagnosed with this disorder, it tends to be more persistent, and it also tends to be more severe. As I'm going to argue at the end of my talk, it's because of the exhaustion of coping as to why we see this particular effect. It's predictable from the model that I'm going to show you. But the fact is that there are differences and there are problematics for the African American population in this particular area. The gender differences in onset, just to summarize some of this, Caribbean black females who are not born in the U.S. are more likely than Caribbean black males not born in the U.S. to have a disorder onset after immigration. So there are things which happen after the immigration event that produces that. No gender differences were found for other anxiety disorders. So just to summarize some of this issue, and by the way, I didn't say this, but I should have. The reason why we focus on the Afro-Caribbean population is because we're trying to separate out what are the effects of race from the effects of ethnicity. Black Caribbeans in the United States share a race with African Americans in the United States, but they do not share an ethnicity. In fact, they don't even live in the same locations, actually. And so this allows us to look at the ways in which, and to answer the most important question, not what's more important, race or ethnicity, but the more important question, what are the conditions under which ethnicity trumps race, and what are the conditions under which race trumps ethnicity? So actually, we're studying this group not only here in the United States, but also in Canada and also in England, and trying to understand this differentiation between race and ethnicity. And we've done tons of studies, but that's not the purpose of my talk today. That's just kind of an aside. But that's the reason why we spend so much time with regard to this particular population group, because we want to understand and disentangle those effects. So there are larger ethnic differences. This is from the CPES. And I don't want to talk about any of this, but to show you that the patterns are different. So this is lifetime event prevalence by race and ethnicity, and you can see large differences among these various different kinds of groups. And it's true whether we look at the differences in groups or we look at those people who are U.S. born and non-U.S. born in terms of what those effects are. So it's clear that ethnicity and also your immigration status, with being U.S. born or not U.S. born, will affect these particular kinds of outcomes. You even see these differences in mean days out of role. For those who are severely impaired, you can see large differences across these particular groups. Again, I don't want to dwell on that. I'm just trying to make the point that the ways in which ethnicity, the ways in which being a migrant or not will push around this particular issue with regard to how we understand psychopathology. This is mean days out of role, and you still see this particular same kind of effect. This shows you the differences between African Americans, foreign-born Caribbeans, and U.S.-born. These are age differences. I'd love to have longitudinal data, but no one's giving me that money yet. Well, you know you need that. I'm speaking to the converter here, so you know that. But there are these particular kinds of age differences that we observe. Whether they're longitudinal effects or not, we don't know the answer to that. But this is going to become important when I get to the meat of my talk about these particular kinds of age differences. So serious psychopathology problems manifest in different ways among race and ethnic groups in the United States. That's the point I was trying to make. Secondly, ethnicity, gender, age are all important sources of these particular differences that we observe. Just looking at one thing is not going to tell you the story. They indeed intersect with each other. We have to understand that. Among Afro-Caribbeans, and we believe other groups as well, immigrant and ancestry status make huge differences in the issues around psychopathology and mental health. First-generation health protection may not be an adequate explanation for the differences that we observe among these particular groups. Differences in psychopathology are not reducible in any particular simplistic way to differences in social and economic statuses. It's complex, it's multifaceted, it's life course influence. And these intersections, they all matter in terms of our understanding of this. And this is what our work in the National Survey of Black Americans and the National Survey of American Life has been trying to stress and to address in terms of how we understand this. But let me talk to the thing that I'm working on right now, which I get very excited about, which grew out of this work in a very real way. And it actually grew out of that finding that non-Hispanic whites have higher prevalence rates for major depression. And that led us to thinking about why, indeed, would that be true. So I'd like to start with this quote, "A mind is a terrible thing to lose." You probably thought that Freud said that, or at least Pogo, some philosopher. But this is Vice President Dan Quayle who said this. And in some ways, my talk today will try to vindicate Vice President Quayle. As you know, he was always getting things wrong. So the date was lost. I forgot when he did this. It's a misquote of the United Negro College Fund banner. "A mind is a terrible thing to lose, to waste." And he said, "A mind is a terrible thing to lose." And actually, I'm going to argue today that that's a very important motivation in terms of looking at the interrelationship between physical and mental health, particularly in the African American population. So the second thing is, this is a quote from the New York Times in 2013. This is about food companies, and the public have known for decades that sugary, salty, fatty foods are not good for us in the quantities that we consume them. Why then are the epidemics of diabetes and obesity still out of control? We know these things are bad for us. I always give the example of New York trying to get rid of the big gulp, which they were unsuccessful on. I predicted they would be unsuccessful because people wanted to hang on to those. There's a reason for that, and we'll be talking about what that particular reason might be. This is what I call "all is right with the world" slide. This comes from 1985, and what it shows is that if we look, particularly focusing on African Americans and non-Hispanic whites, that indeed the rates of disorders would be considered to be higher among African Americans than it was among whites. And this is all is right with the world, because people think that it should be. And why should it be? Because they suffer more stressors in their life, more deprivation with regard to social economic things and so on. This is the way I should look at it. But this is rates under treatment, and a lot of our work has shown that indeed if you want to mismeasure something to do with regard to psychopathology, just look at rates under treatment, since the ways in which people get in treatment is really confounded by a lot of different kinds of issues. So we wanted to go to then household surveys. So we're going to talk about all these various different things. I don't know how this slide snuck in here a second time. Social inequalities in health. I want to note these are some of the most important people, and there are a lot of people in this room who also study the issues about social inequalities in health. I particularly like Link and Phelan's work because they talk about what are fundamental social causes of what we observe with regard to what those differences are. And I'll just give you one slide to demonstrate what some of the health differences are by race in the United States. This is melanoma death rates by sex, race, ethnicity in the United States. So you notice that white non-Hispanics have a rate of 3.4. African Americans have a very low rate of 0.4. That's interesting, and it makes some sense given issues with regard to skin color and tone and exposures and so on. But what's really interesting is that even though it's a 9-to-1 difference, that blacks are more likely to die from melanoma than are whites. This is what we talk about when we talk about disparities. And we can look at almost anything you want to look at: diabetes, cardiovascular disease, it doesn't matter. This is just one example. In the cancer area, there are tremendous differences, and African Americans suffer in comparison to non-Hispanic whites in all these particular differences. The law of small effects, I think I mentioned that before. I can't believe I got that. I want to talk a little bit about the chronic stress process, which I think is one possible pathway for physical and mental health disparities among population groups. So there are links from childhood to conditions that we observe in adulthood. Over the life course, blacks more than any other group live the fewest years, and a higher proportion of those years is in poor health. Health, race, and mobility are linked in very complex ways across childhood, adolescent, adulthood, and old age. So, for example, this is an example. The model that we have predicted this. We argue that blacks may be more highly selected for positive health than whites early in life and also in late life. People are familiar with the late life crossover. If you're black in this country and you can live to 80 to 85, then the chances are that you will then live longer than a comparable non-Hispanic white. Of course, the problem is just getting to 85, but if you can get to 85, then you're going to live longer after that. Don't mind my sense of humor. Anyway, but we argue that indeed blacks may be more highly selected for good health. What this is are death rates at infant, fetal, perinatal, and mortality rates between black mothers and white mothers. And what's important about this is all the time up to 1 year, 1 day of life, African Americans are dying at 2.5 to 3 times the rate of whites over this particular period. We don't put spontaneous abortions in this. If we did, it would be even larger. Our argument is that that has to have some particular effect, that indeed then African Americans are more highly selected after the period of infant mortality than are whites. And in fact, if you look at the data where we disaggregate it by age, everything over 1 really means that whites are better off than blacks. Anything under 1 means that blacks are better off than whites in terms of death rates. And so you can notice, if we were looking up to about the area of 18, there are no disparities. There are no disparities. People haven't disaggregated in this particular sort of way. Notice this sigmoidal curve that shows that as we go along, that indeed African Americans began to die at higher and higher rates. Our argument is that in these areas, African Americans are hardier than whites and are able to resist these stressors which are bearing down on them. But as these stressors take their toll, more and more you see the death rates indeed reverse themselves over the life course in this particular way. You also see this for males. That was females. This is for males. Exactly the same effect. In fact, you even see this sigmoidal effect for all-cause mortality, which includes things like accidents and other kinds of stuff. You can still see the hint of this particular effect. And in fact, if you take a look at the disaggregation of black male death rates, you can see that one of the highest is here, which is infant mortality and earlier, but that the rates are very, very high in this particular area too, if we disaggregate it. I mean, blacks are not living all that long. They are indeed dying out relatively early in life. So poor health behaviors parallel the same things I just showed you with regard to these differences in health statuses and mortality. So if we look at smoking among males, blacks are in pink and whites are in green. You can see early on that indeed black rates of smoking are relatively low. But as we go across the life course and we get to 35 to 44, that indeed blacks are actually smoking at rates that are higher than whites. And our argument is that there's a reason for that. You see the same effect among smoking among females. Very low rates early in life, when indeed blacks are hardier, and the rates increase over time. Even obesity, and obesity is one of the things that shows early differences between blacks and whites. what I really want to argue is that those things which create obesity, overeating, comfort foods, and other kind of stuff, is a very, very effective coping mechanism for black females. And they learn it early, and they continue it, so that we have almost, but 40, 59 years of age, close to 60% of the black American female population would be diagnosed as being meet criteria for obesity. That can't be, in my estimation, a number that big, all to do with regard to the lack of individual character among all those particular people. There has to be a systematic reason as to why we observe those particular differences. If we look at alcohol use, and again, I just want to make the point that what happens is that you see the same increase, so that alcohol use actually increases over the life course to become higher in later years. The same thing with regard to drug use. If you just look at the African American number, they indeed start off relatively low, but indeed in the middle ages and older years, they're higher. The same thing with regard to marijuana use, which is also very, very clear. The argument that we want to make here, and you're going to see, is that indeed, unlike females who find a very effective coping mechanism early in life, which is eating comfort foods and other kinds of things, African American males who are very physically active in young years, when you lose that ability to be physically active, you have to find another coping mechanism. And African Americans then find marijuana, other kinds of drugs, and smoking, alcohol use, and so on. That's the argument that I'm going to make as we get through. This is an interesting set of slides, again, to make the same point. We've been looking at obesity, and this is a predicted probability of obesity by education. And what's interesting about this slide is that for white females, it's very responsive to education. So by the time we look at white females who've completed college, they have much lower rates of obesity than those who are less than high school or high school completed. This is for 25 to 44. If we look at women 45 to 64, you find the same effect. What's interesting about this slide is that for black females, it's totally unresponsive to education. So the black females who are college educated have the same predicted probability of obesity as African American females who didn't complete high school. But for white females, it works pretty well, and the same thing is true for 65 years of age and older. So that, indeed, thinking about the role of education and SES in terms of affecting those things which lead to obesity, they don't seem to have an effect on African American females at all. Vigorous physical activity, this just indicates that at all levels, white females are more active than black females. On the other hand, if we look at mental health comparisons, what we observe is that black-white disparities almost always favor blacks over whites. This is the lifetime prevalence rates for all the major studies that have been done, household studies, ECA, NCS, NCSR, NESARC, ours, NASAL, NHANES, and the same effect is there. Non-Hispanic white rates, which are this bar, I don't know why they're different colors, are always higher than African American rates. The question is, why is that? And we argue that some theory is needed to try to account for these particular differences that we indeed observe. So we talk about the self-regulation of individual health behaviors. There is a relationship between physical and mental health disparities, we believe, and it's about the utilization of stress coping mechanisms over the life course that people engage in. So structural life inequalities are hypothesized to cause both health and mental health disparities, whether stated or unstated. That people believe that the health disparities that we observe between blacks and whites are due to being poor, to being less educated, to living in meaner straits of life, and that produces the differences. people also argue that that should produce the differences in mental health outcomes that we see as well. And if it does, then it has a very peculiar way of doing it in terms of how we understand that. Structural life inequalities are large and unfavorable for African Americans. Physical health disparities and mortality, as I've talked about, are unfavorable for African Americans, but mental disorder disparities are actually favorable, particularly those which are stress-related, anxiety, and mood disorders are favorable to blacks over that of whites. So why? The environmental affordances model tries to explain that in terms of how we understand what might be going on in the African American population to account for this particular effect. And there are only about 4 tenets to this particular framework. First, stress-related precursors of serious mental health problems are more available to people's consciousness than are those of physical health problems. These symptoms, headaches, feelings of anxiety, heart palpitations, are noxious, and individuals are motivated to end them. These are more available to us. You're growing a tumor for cancer, most likely you are in some ways the last person to know that indeed you're growing that particular tumor. It's not available to your consciousness in the same way that the precursors of mental disorders are available to your consciousness. Second, this psychological awareness motivates individuals to action. Unfortunately, a lot of the models in social determinants of health view the individual as non-agenic. In fact, views the individual as a pawn in the things that happen to them and occur to them. That's not true. People are agenic. If these bad things are happening to you, you're going to try to do something to end those bad things. The action is directed toward reducing the noxious symptoms that you're suffering. That's what you're directing it toward. You're not trying to direct it toward the ideologic outcomes as you move toward depression. It's about the symptoms that you suffer. And finally, coping strategies in the face of non-race and race-specific stressors are themselves harmful to people's physical health. So these are efficient, learned responses through instrumental learning that over time become dominant in the behavioral repertoire when the noxious symptom is present. So the notion is, I have a symptom at time 2, and I say, God, what did I do when I had this symptom at time 1? Oh, I ate some cornbread. I'll eat some cornbread now. And then the third time, what did I do the first 2 times? I ate some cornbread. Boy, maybe I'll try some Kentucky Fried Chicken at this particular point in time. Or I had a martini. I'll try that martini because indeed it reduced the symptoms. And don't be fooled. I was a smoker for a long time. You feel better after you smoke a cigarette. You feel better after you have a martini. You feel better after you eat cornbread or fried chicken and so on. And it really does reduce the noxious symptoms. So Dahlman, for example, suggested that rats and people, although she worked with rats, eat comfort food to reduce anxiety in the chronic stress response network. We propose that other behaviors, smoking, alcohol, excessive sexual behavior, and illicit and prescription drug use have similar immediate effects to reduce the activation of the stress response network and provide relief from noxious symptoms. The choices of these particular behaviors are determined by environmental availability, cultural factors, gender differences, ethnic socialization, among other reasons. But the overriding determinant are that behaviors are efficient, sources are available, and they become well-learned, dominant responses in a person's repertoire. As you will note, these efficient behaviors, and this is not to say, by the way, that prayer is not important, that social support is not important, that these kinds of positive kinds of behaviors are not important. they're not efficient. These are not efficient mechanisms for reducing the symptoms of chronic stress among people. The problem with these are that they are addictive, number one, and the second thing is that they are harmful to your physical health. While smoking may indeed reduce anxiety, you may feel better and so on, in the long run, it will kill you. And that same thing is true of a lot of these other things in terms of how they operate. So this is the model. It's fairly straightforward. It says that if we're interested in physical health disorders, psychiatric health disorders over here, it's a function of the environment. It's a function of stressors that people suffer by being in those particular environments. It's a function of the poor health behaviors that people engage in because they are in those kind of environments, and the chronic activation of the HPA axis, which is at the heart of this in a biological way in terms of having those effects. We argue that the effect of poor health behaviors is direct on physical health disorders that we observe. It furthers the activation of the HPA axis in a very strange way, but indeed, it buffers the effect of the chronic activation of the HPA axis on psychiatric health disorders. It influences the etiology of the ways in which chronic stressors lead to the disorders that we observe among individuals and population groups. That's the argument. So there are complex interactions. Sapolsky has talked about that between endocrine and neurological systems. Under chronic stress, you get negative feedback. Long-term chronic activation of the HPA axis may be related to the etiology of some mental disorders. And those are the mental disorders that I'm talking about today. So the stress response network, comfort foods aid in the shutdown of the stress response by inhibiting release of CRF. Alcohol, nicotine, drug use stimulate release of dopamine and beta endorphins, which aid in the shutdown of the stress response and lead to feelings of relaxation and calm. Paradoxically, these drugs may also further activation of the HPA axis, as I mentioned before. There are two hypotheses. The weak hypothesis, that poor health behaviors mask the stress response cascade in individuals, or poor health behaviors indeed actually interfere with the cascade to neural and hormonal events that ordinarily would lead over time to mental disorders. So I'm going to give you an empirical example. You can see where I'm going with this. The argument is that these are structural life inequalities which influence the experiences of chronic stressors and stress, also bad behaviors. They affect poor physical health, and they indeed are hypothesized to have these effects on psychiatric health disparities. For blacks, we argue that these bad behaviors, smoking, drinking, and other things, actually buffer the effect of the chronic stressors on the psychiatric health outcomes. So this is straightforward regressions that we've done, and we're looking at centered stress. This is just more stress, less stress, and you can see at the lower levels of stress, these are health behaviors, bad health behaviors, 0, 1, 2, or 3, and we're trying to understand what the interaction is between stress and these particular behaviors on the probability of meeting criteria for DSM-3 disorders. So you can see there's no differences at low levels of stress, just as we would predict. But as stress increases, you really get a difference. And for whites, you can see that you get this combination effect, high stress and engaging in a whole bunch of these bad behaviors, smoking, drinking, overeating, and so on, increases the probability that you would be a case of major depression. That's for whites. So we said, well, we expect to find the same thing for blacks. And we find exactly the opposite. For African Americans who are under stress and stressors, not smoking, not drinking, not eating comfort foods, leads you to the highest probability of being a case of major depression. If in the face of these particular stressors, you are indeed drinking, smoking, overeating comfort food, then in fact, your probability of being a case of major depression is even lower than under the lower stress condition. So you say, James, I just don't believe that. This is kind of outrageous. It is outrageous. But the fact is there. It's perverse. This is our perverse findings. We will admit to that right away. You know, that smoking and drinking and other kinds of things in the face of stress actually reduces the probability of your being a case. So we said, let's replicate that if we can and see what the effects are. This is the Baltimore ECA studies. And exactly for whites, we find exactly the same effect that we found in the ACL. And for blacks, we find exactly the same effect that we found in the ACL. Smoking, drinking, and other things in the face of being highly stressed is an effective way to impede the probability of being a case, in this case of MDE. Well, if you don't believe that, we'll replicate it again. This is in the NESARC study, and this is the only study. Somebody was here at Columbia wrote this bad article about us that they didn't believe what we had done. I thought that was really kind of interesting. So we went back and took a look at the NESARC data, and the fact was, in the NESARC data, NESARC is not a very well-behaved data set, we call it. And the problem had to do with regard to the measure of stress. And when you correct the measure of stress in the NESARC, we get exactly the same effect that we observe in the other studies, just at a lower rate because it's not a great data set. So we find the same effects with regard to whites, and we find the same effects with regard to blacks. Those are three separate studies which we replicated the same effects for blacks and whites over a long, extended period of time, almost 30 years. And we find exactly the same effect. So what in the world is that about? So we argue the affordances framework addresses the consistent negative health disparities for blacks versus whites. That is, blacks have at least two routes to the negativity in health. One are the behaviors that they engage in themselves as coping mechanisms for major stressors. And second, because they live in environments which are detrimental for the health outcomes. But they have better mental health. Positive mental disorder disparities for blacks and whites. We argue that these things are protective, at least in the short term. And these are major effects of chronic stressors that we observe. And it also accounts for the gender differences we see in poor health behaviors. As I said before, African American females have overall the lowest rates of alcohol abuse, the lowest rates of drug abuse, the lowest rates of all these bad things, but they have the highest rates of obesity associated with this, eating, we believe, comfort foods. And also it addresses the patterns of change. We were very dissatisfied with this. And how can you be dissatisfied? They published our work. We replicated the work. We're certain that indeed the empirical work is correct. But what's wrong with this finding is that even if we don't know what it is, the fact is we're hypothesizing a biopsychosocial mechanism underlying the interrelationship among mental and physical health disparities. We are not saying that blacks have a different biology than what whites have. And if it's the same biological processes, why indeed do we observe those particular differences that we find by race? And that's what we now are exploring, and this is our most recent work. And not a lot of this has been published yet, but this is our most recent work. So skin tone is a very important aspect of what we consider to be race. The instability of skin tone, since it probably evolved last in the human genome as individuals, as people moved out of Africa, that indeed lighter skin tone had to evolve in those locations when more sunlight was needed. to allow for folate so that people could reproduce. So people became lighter as they moved into northern climates and other kinds of places. The fact that skin tone becomes a marker for indeed some deep-seated differences among groups is ridiculous. It evolved last in terms of how we understand things. So we talk about race and ethnicity, its biological and social processes, and the question which is never asked is, why should we observe such large and consistent differences among African Americans and whites in physical health and outcomes, and such inconsistent differences for all other kinds of groups? Why is that? So self-reported race and ethnicity are oftentimes most often used, but what does one social group identity have to do with group disparities? Because if it's about your identity, we can end the whole disparities discussions now. African Americans can declare from this minute henceforth they will be white. And when asked, they will say that I'm white. They will mark on any studies that are done that they are white, and the disparities will disappear because it's all about one's identity. And that's ridiculous because it's not about people's identities. I'm a social psychologist, so as social psychologists in the room will observe, the whole world can be put into a 2x2 table. But think about this on a continuum, self and other. And what's unique about African Americans and non-Hispanic whites in this society is that non-Hispanic whites will say, you're African American, and African Americans will say, yes, I'm African American. So processes of stress, discrimination, and so on can operate outside of anything to do with the self-identity of African Americans. This is not a story about self-identity. It is a story about other identities, other ways in which people recognize people's identities, and the ways in which people are then treated. There are some times when race really does matter. Stereotype threat, race makes a difference. We induce race. People have these things about being a stereotype group. It interferes with their performance on intellectual outcomes. Race makes a difference. Race makes a difference in perceived group major discrimination. And what's interesting about this, by the way, you'll see this really clear. It doesn't matter what your ethnicity is. If you are black in this particular society, you perceive a lot more discrimination than if you are white in this society. The same thing is true for major discrimination because of race in the last 12 months, and the same thing is true for everyday racial discrimination. That is, reports that people follow you around in stores and do these kinds of awful things. You see this. Race makes a difference. But why racial group differences in this complex physical and mental health and psychiatric health processes? So there are issues in race theorizing. Ethnicity is a complex idea, complex interplay among genes, human mixing is a huge question mark, disease risk is a complex issue beyond mere genetic clustering. So I want to argue today that racial group membership is a destination over the life course. It's a destination. Race and ethnicity is not a variable. We cannot assign a race or ethnicity to people like we assign to many other things in our particular society. Instead, race is a very complex construct that in adulthood captures a wide set of life experiences that you can array along as simple dimensions. Individuals become racialized through their lived experiences over the life course within a particular culture during unique periods of historical time. Everybody in this particular society can become racialized. And by racialized, I mean placed into the poorer of these racial designations that we give people. Blacks are more likely, because of their characteristics, to suffer this. But whites can also find themselves in the same situation. And we're going to argue that if whites are racialized in the same way that blacks are, then they should show exactly the same response to stressors and the bad health behaviors. And so let's see whether indeed it does. Of course, you know that it does now, otherwise I wouldn't be up here talking. Of course, I could have had a negative outcome and try to explain it. I don't know, you know. So the notion is this, that we have groups, the advantaged group over time, the moment is, on average, they're better off than the moment of the disadvantaged groups, but the groups overlap. Whites are not free, a point made in this last election, from some of the same ravages that blacks see. Think Appalachia, think poor whites, think about those kinds of circumstances. We propose that an individual's race is best conceptualized, particularly at the end of the life course, as a set of propensities rather than a single mutually exclusive category, and that these propensities change over time and across contexts. Race is not just an input into the stratification system, it is an output as well. We already know that that people make mistakes on who's black when they die. You know, fewer blacks die than are born, just from a demographic analysis. That's because the mistakes that are made in funeral homes and so on, as to whether blacks are really black or not, they're oftentimes, you lighten up a little bit, so you're assigned white. So that, well, everybody knows that. So anyway, we use propensity score analysis to explore the idea that this should not just a story about race, but what becomes associated with racial group membership over the life course. And we use demographic and contextual variables. There's no social or psychological variables in this particular propensity score work. And what we tried to do was figure out how we could assign different racial group characteristics to people who are white or people who are black. So this is the original findings for whites, and this is the original finding for blacks that I showed you before, just to remind you. So this is the highest quartile on the propensity of being black. So these are whites for whom our propensity analysis would say, you're really black, because you meet the propensity of being black. So you have the propensity to be black. And they look just like blacks that I showed you from before. You see this particular effect. So not engaging in these bad behaviors is protected, where before it wasn't. So we looked at blacks. Remember, we saw this particular effect. And this is these are blacks that my staff called, these are blacks who are blacker than black. So that's just a joke. But the fact is that these blacks, based on the propensity score, are really likely to be black. And all you can see, it exaggerates the effect that we observed before. It doesn't reverse it like we saw with whites. This is the lowest quartile on the propensity of being black scores. And what you see is that it doesn't totally overcome the effect, but it really reduces that effect from what we saw before, which is what you might expect, since getting away from being black in this society is hard to do, no matter how much money you have or where you live or what the case may be. So we kind of expected that outcome. So we looked at blacks and whites, regardless of what their original race was, and these are both below the median on the propensity of being black, and both blacks or whites, regardless. You can see that they look like whites. So both blacks and whites are below the median on the propensity of being black, regardless of what their racial designation is, you get this effect. And blacks and whites, who are both above the median on being black, really indeed look like blacks that we observed from before. So physical health and psychiatric disorder disparities cannot be understood outside of a bioecological model. I want to make that particular point. It's very important to understand that. Our propensity score analysis suggests, no, there's not different biology for blacks and whites, but there certainly is different environmental experiences over the life course for blacks and whites, which produce what we observe in later life. So Dan Quayle, may have inadvertently been correct when he stated that a mind is really indeed a terrible thing to lose. Because we want to argue that indeed people are motivated when faced with the symptoms that ideologically could lead to major depression and anxiety or those stress-related kinds of things, will do anything to avoid those particular symptoms, and it avoids that particular kind of outcome. The underlying motivation for what on the surface is often viewed as inexplicable, or failures of individuals in group character, human behaviors, may be related to the experienced symptomatic consequences of living under chronic stresses and stress, and the overwhelming human desire to avoid psychological disorganization as to why we see this particular effect. Self-medication must be considered within a larger theoretical framework. A lot of time I give this talk and people say, well, we know that all along. People self-medicate. Why do people self-medicate? What's the effect of the self-medication? What's indeed the larger theoretical framework that you're putting self-medication in? This framework says it helps to explain how it fits within this larger net. Human agency, which I think is important, individual motivation, and individual behaviors have to be considered in any theoretical formulation to explain population differences in health that we see and disparities. So we need to focus more on heterogeneity. The explicit assumptions of homogeneity in research is not tenable. And the example in the environmental affordances model tries to demonstrate we need to be very careful. The masquerade of what on the surface may appear to be racial group differences in complex biopsychosocial ecological phenomena may not be that at all. Thank you. That man does go on, doesn't he? Didn't mean to do that. We have some time for questions. Or comments, either one.
Hi, thank you so much for this wonderful talk. I had a quick question about when you talked about the propensities and how, what factors went into determining that and what was considered the propensity of being black.
What factors went into the propensity score now?
Yeah.
Yeah, I showed those. So, no, that's all right. I can go back to it because, sorry about that. It's probably an easier way to do this, but I don't know what it is. So those are the factors. It's very important to note a more powerful analysis would actually include social and psychological factors. But we wanted to avoid, the apples on one side of the equation and, different kind of delicious apples on one and what are the red apples on the other. So the idea was that we use age, gender, marital status, labor force status, people in the household, education, income, financial strain, neighborhood characteristics. Those are the factors. These are but no social, no psychological factors at all, like perceived discrimination or other kinds of things. All right? I mean, you can see why we did that to start with.
Thank you, James. That was wonderful to hear. My exact question was going to be what went into the propensity scores. So thank you very much. So I can ask my second question.
All right.
Do you think this explains the case in Deaton's finding of an increase in suicide among one particular group, which was mainly less educated white males? If you put the propensity scores, would they become black? Yeah.
So these are the people who, although would probably be horrified if they heard my talk,
Right.
and the comment that I'm going to make next, they would really be horrified. Yeah, these are the people whose lived experiences are going to most parallel that of what African Americans experience. And there's lots of hints to this. Tom Levis, for example, in his studies, which showed that blacks and whites who lived together indeed had outcomes. The NSAL, a lot of people don't know this, but the NSAL actually is conditioned on whites living in the same areas for which blacks live in.
Yeah.
And believe it or not, no one's done that analysis yet. And our argument is that in those conditions, that those whites will look more like blacks than they will look like whites. We're just now extending this to talk about the life course and what happens as people live their lives and whatever. So this accounts for why there are certain blacks who live really good lives, particularly if they're living in Atlanta, if they're living on the east side of New York and other kinds of things, who can escape some of the ravages of being black in this particular society because of their higher socioeconomic status, of higher education, of all those particular kinds of things. They don't fully escape it, trust me on that one. Why can't, Danny Glover get a cab in New York City? But the fact is that indeed you can see why that's the case and why poor whites who live in the other kinds of things indeed may look more like blacks. But the argument why we started this is because here we are talking about the HPA axis and all that kind of good stuff and these cascades and all that kind of biological stuff. And then we find these big racial group differences in what we observe. And is there a different biology here? And our argument is no, it's not about the biology. It's about the environment and what environmental experiences people have over time. All right? I don't want to beat that dead horse too long, but, so we'll see. Everybody else agreed, huh? That's good. There's a young man down here, too.
Okay. Should I?
He meant me.
Okay.
Thank you for that. I had a question about that was triggered by Myrna's question, actually, and that is that one health outcome that's remarkably better is the very low suicide rate in black women. And I wondered whether you had any thoughts about that.
Yeah, we've done some work on suicide. I think we published a JAMA article back in 2006 using the NSAL data. It's not an area of great expertise for me, but there's an old joke that probably has some real truth to it. If everybody else is trying to kill you, you don't have to kill yourself. And I think that's actually been true for African Americans for a very long time. Actually, there are problems in the African American community with increases in suicide. And the largest increase seems to be in middle and upper class African American males, where you're seeing the increment in suicide. We believe that the affordances model actually accounts very neatly for that. I've spoken to community groups about it. One of the things that happens to middle class African American males in this particular society is that they are told that they need to learn to play the piano. They need to spend more time reading. They need to spend more time. Don't spend your time on the basketball court or doing other kinds of things which young African American males do. Of all the race gender groups, African American males are the most active, particularly in young life, but actually it lasts up to middle age. Exercise is an effective coping strategies in the face of stressors. I was going to write President Obama one time. He was still trying to play basketball, and explain to him that indeed, as his knees went out and other kinds of things, he needs to probably start thinking about other forms of coping in order not to turn to the kind of bad ones. But we really think that indeed, that's why we observe this particular kinds of differences. You asked another question, which I think is important, and this is about white females. We published an article in Health Affairs in 2012, which talked about why the mortality rate increases in low-educated white women. So we had argued, and we haven't published this yet, although we've done the analysis, we argue that why we see those particular differences is because young, uneducated white women are doing bad things. And so using NHANES data and so on, we can demonstrate that it's in this group for which you see increases in overeating, increases in smoking, increases in drug use, increases in alcohol use, and so on among those groups. Because indeed, they're one of the most highly stressed groups within this particular society at this particular point. But it accounts for why the mortality rates have increased so much over that particular 30-year period, unexpectedly, by the way, that people saw. Okay? Was there one?
Yes. Thank you, Dr. Jackson. This was really very inspiring. I was very interested in the life course, early life course piece of your talk, and what would be if people have looked at those differences very early on, and what would be your predictions? Because we have now a intergenerational study, so we would be able to maybe look at some of those early disparities and protections. So.
Well, that's in some ways this turned out to be one of the most outrageous things that I've said. We published this. Most of the time, people don't just aggregate by age or position in the life course data on disparities. And we argue that the particular framework that we had would argue that indeed African Americans are hardier at younger ages. And we're just arguing that there's only one assumption that you need to make about what we found. And the assumption is weaker organisms die before stronger organisms. That's the only assumption you need. Because at every point, up until 1 year, 1 day of life, right, African Americans are dying at 2.5 to 3 times the rates of comparable whites. If you add into that the extraordinary efforts at all those particular periods to save non-Hispanic whites in this particular society and not African Americans, you can see why at 1 year, 1 day, we argue that African Americans are stronger organisms. And right now, we're doing a lot of data. Well baby checkups show this, bigger, taller, among African Americans and non-Hispanic whites. There's lots of data that we're now collecting to make an argument to support that particular argument. But the fact is that if you are born into an African American household in this society, you are more likely to face stressors and stress that a person born into a non-Hispanic white household does not face. Whether that be single-family households, whether that be poverty, whether that be awful environmental conditions, and so on. And the idea is that over time, being a stronger organism, you can resist those particular kinds of stressors, but it's going to catch up with you. And by middle age, African Americans are dying at greater rates than our non-Hispanic whites. But it accounts, I think, very neatly than having 1,000 different explanations as to why black drinking rates are low in adolescence and young years, or why drinking rates are low, or smoking rates, and all those other kinds of things. Because blacks are more religious, because there's more of that. So we argue that, no, they really truly are stronger organisms. They can resist the stressors. That's the argument. That's the hypothesis. Remember, the idea of the model is to generate testable empirical hypotheses. And to the extent that our findings, are supportive, then it gives us confidence that the overall theoretical model makes some sense. Yes?
Thank you for the talk. The theoretical underpinnings of this mostly seem to suggest a mediational model in the sense that African Americans are more likely to use these highly efficient coping strategies, which result in them having lower rates of mental health problems. But the data you present is really a moderation model, and it has to do. And what it's showing is it's not particularly efficient for whites, or at least not whites who are propensatorily white. And so I'm not. What do you see as the basis for that interaction, for that difference in efficiency of the coping strategies across race?
Notice that the interaction, which is really important, we tested a lot of mediation models. In fact, that's where my thinking started. And it turns out that was just wrong. I mean, this is a classic buffering effect. You know, at low levels of stress, it doesn't matter. It literally does not matter for blacks or whites. That's what it shows you. At the lower levels, it doesn't matter what bad behaviors you're engaging in. There's nothing going on. But at the upper levels and higher levels, those are standardized stress models. And by the way, our measure of stress is nothing to write home about. The measure of stress is about the number of life events that people have, which is added and then standardized for this particular period. We've actually created, this is some of our clinical work, and I just don't have time to talk about it. We've created a new measure, symptom-based measure of stress that I think is a much better measure than this kind of life events approach. This is crude. What I showed you this is crude, and yet we get these particular effects which seem to make some sense. So it's a traditional buffering model that indeed engaging in its behaviors, indeed either through the weak hypothesis or the strong hypothesis, really influences this etiological cascade toward becoming a case of major depression. That's the argument that we're making. And remember, these are longitudinal data. God, there's so many things to forget. All right, I just want to say that these were longitudinal analyses, and it had to do with regard to predicting becoming a new case, controlling for any caseness at time one. So we control, everything is controlled out in these studies I showed you. I mean, we control SES, we control gender, we control, age, we controlled everything that we could think of in these particular models, and even controlled time one, whether a person had been given a depressive disorder diagnosis. And we're looking at new cases. So incident cases at time two is what the outcome was. Sorry about that. I forgot I was talking to a group of psychiatrists, but a group of social scientists, they wouldn't care.
Hi, Dr. Jackson. I've been a disciple of yours for a long time, so I'm so grateful that you're here. But I find the hardiness explanation a little troubling. Do you have any sort of reticence about that sort of explanation?
What explanation?
Hardiness among young African Americans?
Yeah. Well, it's not anything, so it's not I'm not proposing this as a psychological construct. I'm not proposing, which a lot of people do. They talk about this hardiness, whether they talk about John Henryism or a whole bunch of different kind of stuff. I'm not talking about that at all. I am talking about a mechanism which is just about selection. This is a selection mechanism, and all it's saying is that if weaker organisms die before stronger organisms, then African Americans at 1 year, 1 day of life have got to be stronger than the ones who died all the way up from conception to that particular point. Trust me, there's nothing social or psychological about that particular explanation. What should be most disturbing in what I said is that here, and for all the wrong reasons, so I'm not arguing for the fact that we should kill people earlier, before 1 year, 1 day of life. That's not the argument. But these things are happening for a lot of reasons. This is a population that should be nurtured and taken care of. And on the other hand, what do we do in this society? we place them in incredible harm's way in terms of the environments they're in terms of the resources that they have available to them, and all the rest of it. So even though being hardy, although I try not to use that term, being more highly selective for positive health, these stressors bearing down on them lead African Americans, particularly males, but also females, to die at huge numbers in midlife. I showed you those data. Those are tremendous numbers. I tell people all the time, I said, you know, I'm only the second male in my family that ever received full Social Security, ever, of all the males. And that is, I made it to 65. It just doesn't happen for African American males. And I showed you those data. But that's a shame. It's a shame. I didn't mean to get on the soapbox here, but, you know, got to call them like you see them. All right, thank you.